that, we will start with our academic sessions. The first session for today is on acute pancreatitis, first week. I would like to invite our moderators and chairpersons on the stage, please. Dr. Sunil Dadich, Professor and Head of SN Medical College, Jodhpur. Dr. Kinsuk Das, Senior Consultant, Apollo, Kolkata. And Dr. Bikash Chaudhary, Senior Consultant, Guwahati.
Again, good morning from us, both co-chairs and me. I'm Kinsuk Das from Kolkata. Let me start before going to the session. See, in school life, we were born and brought up listening one name in the country, CMC Fellow for Gastroenterology, in my school life of class 5, 6, 7. And then I am in medical profession for more than 40 years and gastroenterology for 30 years. But God, the destiny, has not given me an opportunity to see CMC Fellow. I'm really grateful to Pramod and Sudipto for giving me an opportunity to come to real heaven of gastroenterology of this country. I'm really grateful. This is out of the pancreatitis session which we are chairing, but I thought from my emotions, it's a great day for me to come and learn something again from Sudipto, Pramod, all dignitaries, international faculties and here. So this is a golden hour of the pancreatitis, the IPC club conference. This is the golden hour. And this golden hour, we are starting with the golden hour of acute pancreatitis. And as we are starting with the first talk on acute pancreatitis, is predicting severity in acute pancreatitis, the biomarkers, the scores, or clinical intuitions which should guide us. I think clinical intuition cannot go anywhere away. And to talk to us, to learn from Dr. Ashish Agarwal, Associate Professor, Department of Gastroenterology, AIIMS, Jodhpur. Sunil, you want to say something?
Just want to ask the organizer, do we have any time for questions and answers also? Because the 1 hour is full packed, so will there be some time for the... Ashish, you can start, please.
Good morning, everyone. First of all, I would like to thank Dr. Sudipta for giving me this opportunity to give a talk and visit CMC again. CMC was a long-held dream. I had never been to CMC, and this is my first time. So we'll be talking about the various biomarkers that are available in for prediction of severe acute pancreatitis and try to figure out which should guide us. In brief, the natural history of pancreatitis, acute pancreatitis is either interstitial pancreatitis in 80 to 85% cases, and in 15 to 20% cases it is necrotizing. The interstitial pancreatitis, generally it's mild with a mortality rate of less than 2%. While the necrotizing pancreatitis can be moderate or severe. The moderate one is the one which has transient organ failure or has local complication. Again, the mortality is less than 5%. The most severe form that is defined by the presence of persistent organ failure is the one where the mortality with acute pancreatitis lies at somewhere around 15 to 20%. The overall mortality rate of pancreatitis is somewhere around 2%, majority of which is being contributed by severe pancreatitis. And thus it is very important to predict which are the patients who are likely to have severe acute pancreatitis if we want to bring about a change in the mortality figures. So what is the need to predict the severity? As we have seen that the disease course is heterogeneous, majority of the patients are going to have mild pancreatitis only, with only 15 to 20% patients developing severe pancreatitis. And the severe pancreatitis, to call it a severe pancreatitis, we need at least 48 hours persistent organ failure. The disease is going to evolve over time. A patient who's appearing mild pancreatitis right now might evolve to develop severe pancreatitis. If we are able to predict early, it will help us in guiding the clinical decision. We can decide whether the patient gets an admission in the ward or in the ICU. We can decide regarding the management. The patient might be requiring more aggressive rehydration, organ support or antibiotics. And if the center is not equipped to manage a predicted severe acute pancreatitis patient, the patient may be referred to a tertiary care center. So it's very important to predict these patients. And second, for research and comparability. Again, as I said, that the disease evolves with time. So if we have predicted severe pancreatitis patients early, it can help us compare outcomes across different studies. It can help us test newer therapies in a well-stratified population and thus establish evidence-based guidelines. The predictors of severe acute pancreatitis are either clinical predictors, there are biochemical predictors, and then we have various scoring system which combines both these clinical and biochemical predictors. The patient factors, we know that patients who are alcoholic, patients, obese patients, elderly, patients who are having higher number of comorbidities, patients with steatohepatitis and hypertension, all these are the factors which predict the development of severe acute pancreatitis. Clinical examination, source is very important in predicting severe acute pancreatitis. It's very easy to calculate, just 4 parameters are there: temperature, heart rate, respiratory rate, and WBC counts. It's very simple and it can be repeatedly calculated during the course of the time. The source at admission is very highly sensitive, that the patient is likely to develop severe acute pancreatitis, but specificity is very low. However, if the SIRS is persistent beyond 48 hours, the specificity also increases, and thus overall persistent SIRS at 48 hours performs better to predict development of severe pancreatitis. Others are patients who are having a decreasing urine output, patients who are having altered mental status, they are likely to have severe pancreatitis. Biochemical parameters, the first one we have is BUN and hematocrit. These both are markers of intravascular volume. So we know that pancreatitis has a lot of extra third space losses, and BUN and hematocrit gives us an idea about what is the intravascular volume status. More important is, rather than giving us a volume status, we get to know what is the quality of your volume resuscitation. Thus, rather than having the absolute value, the change in the value is more important. If the values are increasing or they are not decreasing, that means the patients, we are not able to, our resuscitation is probably not adequate. And they are again readily available, and they are a component of most of the scoring systems that are available for pancreatitis. Then we have the inflammatory markers, the CRP. Its accuracy is low in the first 48 hours, but beyond 48 hours, a cutoff level of more than 150 milligrams per liter has a very high sensitivity again to predict severe acute pancreatitis. But again, this is also not used alone usually, and it's usually a component of one or the other score. Other than that, we have an entire list of parameters, biochemical parameters, which have been used to predict. We have calcium, albumin, NLR ratio, urinary trypsinogen antigen associated protein, PMNs, procalcitonin, IL-6, angiopoietin 2. And every day we have a new marker that is being said to predict severity of acute pancreatitis in a better way. But as you can see, the accuracy ranges are between 60 to 90% for most of the predictors that we have. Some are a bit more specific, some are a bit more sensitive. If we talk about scoring systems, again, we have more than 20 scoring systems, already validated scoring systems available by now, and every month we have another scoring system which is combining the different parameters and trying to predict severity of pancreatitis. Dr. Sudipta told me that for IPC also we have at least 6 different presentations for different scoring systems to predict severity of acute pancreatitis. Some of the scores are there to predict the severity of acute pancreatitis. Others are to predict the less severe ones, or the mild acute pancreatitis. The standard ones we'll briefly discuss. We have the Ranson, which was the first scoring system given in 1974. Then we have the Apache 2, which is not specific for acute pancreatitis, but it's a general score which is used to decide severity of any disease and mortality in the ICU patients. The third, we have the BISAP score, which is easy, just five variables, and this was also given to predict mortality of acute pancreatitis. Most of the scores, again, which we are discussing, they are to predict mortality, but they are being used to predict severity here. Ranson score is comprehensive. It has got multiple parameters, 5 at baseline, 6 at follow-up, and it is specific to acute pancreatitis. Apache 2, though not being specific for acute pancreatitis, but it can be calculated within 24 hours. It is a dynamic score. It can be calculated every day. You can know whether if the score is increasing, that the patient is worsening. If the score is decreasing, the patient is improving. Overall, it has the best performance compared to all the other scores. While BSAP score, it's easy to use, just 5 variables readily available, can be used within 24 hours. Again, it's specific to acute pancreatitis. It has higher sensitivity and thus higher negative predictive value. That is, a score less than 3 can very well rule out severe acute pancreatitis rather than predict severe acute pancreatitis. Limitations being that for Ranson score, we need at least 48 hours. For Apache 2, we need a lot of predictors. Most of them are available in ICU only, and it's generally not used clinically and mostly used in clinical trials. With BSAP score, we have lower sensitivity and specificity. So which score is best? People have done multiple studies. We'll be just briefly discussing the first systematic review from 2014, where they used 7 studies, and they found, it was done by Japanese, they found out that the Japanese severity score was the best in the first 48 hours, and SIRS was a poor predictor. Another systematic review came in 2020. They found that IL-6 had the best early prediction of severe acute pancreatitis. The recent systematic review that has been published in 2024, it included 23 studies, 10,000 patients, of which 20% patients had severe pancreatitis, and 10 predictors were evaluated. Of this, they found that Apache 2 overall had the best overall sensitivity, and when using Apache 2 as a reference, albumin, CRP, and IL-6 had better specificity compared to Apache. We also have a lot of emerging predictors. We are trying to combine different predictors in different combinations. We are trying to combine different scores. We are using molecular genetics. We are using orointestinal microbiome. We are also coming up with AI and machine learning models to better predict severity of pancreatitis. So everyone is in the race. We are trying to get the best score, but we do not have. Most of the available scores have some or the other limitations. The first important limitation that we need to understand is the role is to predict rather than diagnose. Early prediction is needed to be important rather than the patient once he already has severe pancreatitis and we are saying, okay, you are likely to have severe acute pancreatitis. It doesn't make sense. But if you see majority of the predictors, they work at 48 or 72 hours to give their best sensitivity and specificity. Second important limitation is that the only job of predictors was to predict severe acute pancreatitis. But the problem that is happening is that most of the prediction scores have poor predictive value, that they are not able to predict severe acute pancreatitis. They definitely have better negative predictive value, that is, they rule out severe acute pancreatitis, and at best only 50% are accurately predicted. This is a very important recent study that was published. This is a systematic review to assess clinical utility of these scores. 43 studies, 14,000 patients. The pool pre-test probability of SAP was between 16 to 25%. And on the right side, you can see if the score was positive, none of the score was able to predict it right in more than 50% of the patient. And when it was negative, the post-test probability went even further low, suggesting all such scores perform poorly in real-life scenario. Now, the third important problem is, okay, we predicted it, that the patient is likely to have severe pancreatitis, but what next? We believe that, okay, if we are able to predict severe acute pancreatitis early, we'll start appropriate therapy early, we'll use aggressive goal-directed therapy, and we might have better outcomes. The problem is that we yet do not have the definitive therapy available, and the management of pancreatitis remains more or less standard. Even the AGA technical review found the same, that they did not find any particular evidence to state that goal-directed therapy improved any important outcome in management of acute pancreatitis. And the fourth reason they do not work well is that we believe that early prediction will help us in appropriate triage and admission. But the problem is that there are different scores, different prediction. Acute pancreatitis is a mild, is a dynamic disease. Our prediction scores are not working properly. It's rather creating an admission dilemma. The patient looks fine to me. The score is coming high. Where should I admit this patient? Should I admit the patient to the ICU or to the ward? An easier option could be admitting all the patients with acute pancreatitis to an intermediate care unit. If he worsens, he might be shifted to the ICU. If he's improving, he can be shifted to the ward. The guidelines also do not recommend using any particular score at this point of time. They rather recommend using a holistic approach. For example, the ACG guideline 2024, it recommends that use everything that you have. Look at the patient characteristic, look at the presence of SIRS, look at the laboratory findings, the BUN and hematocrit, look at the radiology, whether the patient is having multiple collections, pleural effusions, extensive pulmonary infiltrates. These use all of this as a whole rather than depending upon a single predictor. The IAP 2025 guidelines that was recently released, they suggest that SIRS and persistent SIRS is the best predictor, along with when you combine elevated CRP or IL-6 at day 3. So this combination of predictors can be used to predict severe acute pancreatitis. To conclude, early identification of SAP is critical, but it's still challenging. There is no perfect predictor available at this point of time. Use severity predictors as guides and not absolute determinants that use everything that is available, and pragmatic use of available tools and clinical judgment is paramount. And rather than getting into the race of finding a new predictor, it's important to shift our focus towards understanding the disease mechanism that may yield better outcomes in the form of finding a definitive therapy for pancreatitis. Thank you.